Hello everyone and welcome to the October ALiEM Book Club Google Hangout. Today we'll be discussing When Doctors Don't Listen, How to Avoid Misdiagnosis and Unnecessary Tests. And we're fortunate enough to be joined by author Dr. Lena Wen. How are you doing today?
I'm well. Thank you very much for inviting me to be here today, Scott.
Absolutely. So I figured maybe we can begin this discussion if you wouldn't mind giving a few sentence synopsis of your text and we can jump into some of our questions for discussion.
Sure. So when I was a medical student, my mother was misdiagnosed for over a year before she was finally diagnosed with what turned out to be metastatic breast cancer. And I became her caregiver at the same time that I was going through my medical training. And in the process, I learned a lot about what the disconnect is between what is it that patients need in their care and families need in their care, and what is it that doctors are doing. All of us as doctors and nurses and healthcare providers, we don't mean to do the wrong thing, but sometimes there's miscommunication. And I wanted to be able to empower patients and their families to best help their doctors help them. And so I wrote this book based on the idea that listening and that history is really so critical. And that's the message that I want to communicate to doctors, but also to patients to really be able to tell their story well.
Yeah, absolutely, and I think one of the best parts about this book is that it's really engaging for both patients and healthcare providers and provides useful, not only actionable advice, but general perspective for both. To start our discussion, I thought a good place to begin with maybe a broader perspective, and like you said, a lot of the healthcare interaction involves the empowerment of patients and also the physicians or healthcare providers' general receptivity to that. And so our first question I was wondering is, in general, this sort of participatory medicine requires a pretty significant investment from both doctors and patients. And given that we see a lot of disparity in health literacy, how much responsibility should we expect patients to take for their role in this relationship with healthcare providers? And how can we sort of foster this continual growth like you have in promoting patients in this role?
That's a really great question. As you said, participatory medicine isn't necessarily intuitive, right? Because in our culture, we learn that the doctor's almost like the parent. That the doctor says, take this medication, you say, sure, the doctor recommends a treatment, and you don't question it. And so I think the biggest challenge is that it takes a change in mindset. It takes a change from mindset of, I am the passive recipient of care to I'm going to be an active partner in my care. And what I tell patients is that the investment that you make is, first of all, really critical for your health, but second of all, it's not that significant because you don't need to be the expert when it comes to everything medical. I'm not implying that you need to get your own medical degree or even go online and research all these conditions. What I ask for people to be an expert on is their bodies. And what I mean is you should know your own medical history. You should go to the doctor every time with a list of your medications and your dosages. You should have a general idea of what tests you're getting and be able to ask questions about risks and side effects and benefits. And most importantly, though, you should know your own history, the story of your illness. And that's something that every patient can prepare for. With respect to the doctor, you're right, it's also an investment, but more an investment again in terms of the cultural mentality, the mindset change. If doctors were to invest just a few more seconds every time listening to their patients, that could save a lot more down the line when it comes to unnecessary testing. And so this is something that I actually believe will save cost and save time, but the mindset has to change around this issue.
Absolutely. Jordana, do you have any comments on that, investment of the health literacy of patients also?
Um,
Any of
yeah,
your experiences in emergency medicine? We see a huge perspective or a huge difference in health literacy that patients come in with.
I think this topic is just so important. And we try to spend a lot of time understanding what health literacy is and explaining that relationship with our patients. So working in New York, there's barriers often to health literacy, which are language barriers in addition to just education barriers. So that was something I thought of as I'm reading this book. I'm like, this is fantastic, but how does this apply to a majority of my patients who there's communication barriers and maybe education barriers too. And I think the next step would maybe be to consider that population too, and how can we best educate when we have gaps in there's more in the way in our communication there. But this concept of a movement towards participatory medicine is definitely where we need to be going, because they're really, as described in the book, we've really gone away from that, and the way we're training is that we aren't spending time having that conversation with our patients. We're not emphasizing, our role is really to educate our patients and help them make the right decisions. So I think just developing in our training and our practice to have the right questions to engage our patients, maybe find out where they are, maybe diagnose them as where are they on that health literacy scale, how much do they know about what they're experiencing, how much do they know about what this test is and what we're going to find on this test. So what I loved in this book was that they give 3 cases as examples that we move along the book with. And you can see that if there were conversations that happened between the patient and doctor, there would be a better understanding of where their care was going.
Absolutely. I would love to actually see, like, for instance, the case of Jerry the mechanic over a language line, to see how that would definitely change some of those questions asked. Maybe, Dr. Wenda, any tips or suggestions for things that we might be able to employ in those situations where the literacy is low, or there is just a huge communication barrier that definitely interrupts some of the normal conversation that even physicians who aren't exposed to ideas of participatory medicine, see as a huge obstacle?
So studies show that doctors will interrupt a patient in about 10 seconds after they start speaking, which I think is really shocking. I mean, this is not what we learn in medical school, right? When we learn history taking, we certainly are not told, oh, interrupt the patient after they've basically barely said their name and start asking them a litany of yes-no questions. And I'll even give you just a thought experiment too, that if you haven't seen an old friend for a while and you're seeing them for the first time after some time, and if you say to them, oh, are you married? Are you divorced? Are you employed? Did you finish school? I mean, you'll get some answers, but probably not nearly the nuance or depth as if you just asked them for their history. And the same thing for patients. I actually think this is something that transcends literacy levels and culture and language, that many people have this mentality of, I'm going to come in and the doctor's going to ask me questions, and I will answer them. But that is not what's going to lead to better care. We also know based on studies that 80% of your diagnoses can be made just based on the history alone. And so that's why it's absolutely critical to be able to tell your story and share your history in a coherent way. So for any patient, whether it's a patient who speaks brilliant English and is a professor, or another patient who may not speak such great English and maybe is even using a translator phone, it's still critical to tell your story. And to that effect, to be able to practice your story in advance. It's difficult to just come in and tell a perfect story in the same way that it's difficult to come in and give a perfect speech or to give a perfect pitch, a sales pitch to your boss or whatever the case might be. And so think about it that way, that you as the patient need to be instructed as to how to convey that better story, and also the physician needs to spend time listening to it.
Absolutely. And, I think that leads us great into our next question for discussion about, how can we, you point out there's ways that we can sort of measure the way people interact with patients today as healthcare providers, such as like timed interruption, or a lot of different ways that we think about conventionally, how well did a person conduct an interview with a patient, finding out some of those very concrete answers to questions like, were you married, do you have a history of this disease? But for shared decision-making and participatory medicine, do you think it's sufficiently well-defined to sort of monitor the extent that this type of care is being delivered, that healthcare providers are delving into this patient's narrative and truly understanding their story and involving them in the care that they provide? Is it measured enough to an extent that we can sort of understand how it's being rolled out, or areas that we can improve upon it more?
You're right that this is not such an easy area to measure in terms of, how exactly are we engaging in care, right? Is it the number of questions that patients ask? Is it that a decision is made that they say, I'm making a decision? I mean, how is it really, how is this really working? And I would actually caution against a specific measurement, because the last thing we need is more checkboxes, right? I mean, I hear so many questions being asked just because we feel like we have to ask these questions. I mean, somebody comes in with chest pain, and we ask them about back pain. Almost everybody has back pain at some point in their lives, and so the patient is left thinking, well, what does this mean? Should I say yes to back pain? I think it's unrelated to my chest pain, but maybe I should be honest. And we ask them about back pain because we're thinking, could this be a dissection? We have this box in our heads that we have to check, but that's not particularly helpful for making a diagnosis. So I would say that shared decision making to me has three components. The first is starting out with a partnership and really engaging that patient in this dynamic of we're partnering for our care. And that involves getting to the diagnosis together, explaining how to get to the diagnosis, and really just engaging the patient fully as an equal partner, not as a you're the child, I'm the parent dynamic. The second component is to involve the patient, and conversely, to be able to, as the patient, feel totally engaged in decision-making about testing, not just about treatment, which tends to be where decision-making, shared decision-making movement has been, but about testing, because we know that testing is a means to an end, and that often patients are told, you have to get some tests, but are not told what blood tests, if any, whether it's a CT scan or a chest x-ray or whatever, and then the patient gets very confused, actually, about what they've gotten at the end of the day. And I'd say the third component of that is have shared decision-making about what happens next, and a shared understanding of that disease process. So leaving every visit with the diagnosis, or at least with a working diagnosis or some idea of what you have as a patient and what to do from here. I think those are all kind of key components, and a holistic measurement rather than a specific point-by-point measurement is the way to go.
Absolutely. Jordana, any thoughts on, I know we were talking about a little bit earlier before we started the Hangout on, sort of incorporating these ideas more into our own practice, or for my sake, learning forward, ways that we might be able to internally measure our own progress, whether it be like reflecting on how we are progressing as, a more patient-centered physicians or healthcare providers. Any thoughts on how some tips in the book might have influenced your thinking on that?
Yeah, well, what I liked about this book was that it was really focused on the patients, and it was written for patients. So other material I've seen on this subject is focused on the doctor and teaching the doctor how to better engage the patient, which is definitely helpful and necessary, but this is really filling a gap here in the patient side of that conversation. And I think as physicians, we're very aware of that when we see a patient and they don't have their medical list with them, or they don't know what medicines they're on or what diagnoses they've had in the past, and it really hinders the care we're able to deliver to them. So that's something I think that is clearly important, is that this is participatory and that we have both sides are educated on how we can work together as a team. I think as physicians, we can ask the right questions. We can ask, what brings you here today? What do you think is going on? Because I think patients really do have a lot of these answers for us, and it can direct our care. And then we can tell them why we're getting, what we're looking for, and what our plan is if we see something or if we don't see something, and continually discussing our working diagnosis and our ends disposition plan. And really, I think I've tried to work these conversations into my practice, and it actually saves me time because my patients are happy. They're not asking, when's this going to be done, what's going on here. They feel that they have an understanding of where we're going. And I think that prevents patients from returning to the hospital or returning to the ER, their physician, or going to other physicians. So I agree with Dr. Wen that this is probably going to be cost effective if we move in this direction, and also clearly better for both patients and physicians.
Yeah, and I think that was really beautifully outlined in parts throughout the book, especially in terms of the patient participation aspect. I think my favorite part was actually encouraging patients to become a more active participant in the physical exam. And I thought that especially hit home because as a patient, for so long before entering medical school and learning some of like the mysteries of the physical exam, it did seem like this mysterious ritual that you would go to the physician and they would tap on some stuff and feel here and there. And it did feel more of like a scientific examination as opposed to a sort of really compassionate relationship at times, even especially if it started with cold hands. And so I think, especially for me, in terms of looking forward and reflecting on how I might be better as a physician to incorporate these principles into delivery of care in my future education, it really comes down to a reflection in that process. And I think, Dr. Wayne, you hit it really on the head, saying that there might not be a specific metric that people can measure, but I think there definitely is a great sense of, wow, that interaction was like a slam dunk, or that really went well when you have those interactions with patients, especially as a patient. I felt that before with great physicians.
Yeah, and I think nothing really feels more rewarding than that, when you know that you really created a bond with your patient and they're happy with the care and that they feel like a question's answered. Because there's nothing that people are more concerned about than their health. And when they know they can trust you and that you're talking to them and you're listening to them, it's just really one of the most rewarding experiences.
You're right, and this is also why we went into medicine, right? I mean, for all that people might complain about burnout and about issues in their everyday life and whatever, as reimbursement or malpractice or whatever, as just concerns that doctors may have. Ultimately, we went into medicine because we want to heal, because we want to make people feel better at the end of the day after having seen us. And I think, often we forget how scary that experience is for the patient. It's every day for us, right? We see 40, 50 patients in the ED, and it's normal that we see people in the hospital. But it's not normal for our patients, and I think it's something important to keep in mind. And just that act of explanation, I think Scott and I were talking earlier about you have a trauma patient coming in, and the trauma patient is just frightened out of their mind. Now they were in a car accident, and now there are 25 people surrounding their bed. They don't know what's going on. You don't need to start right now with here's the airway, here's the breathing. I mean, it takes 5 seconds to say to someone, you're in the hospital, we're going to take good care of you, you're going to hear a lot of people around you, but we're all talking about you and helping you. Something like that could be so reassuring and really brings us back to why all of us are here. So thank you for that reminder too.
Yeah, I guess, hearing that dialogue from you, it's just clear that should just be part of our regular practice. It should be what we're taught and what we're hearing around the hospital, what our learners are hearing from their senior residents or attendings. And I hope we're moving towards that being more standard in our practice.
Yeah, and I think an interesting jumping point from there is some of the issues also touched on in the book involve like the education of physicians and healthcare providers, and I especially love how that was broken down for patients, because I imagine at an academic medical center it has to be so confusing, from medical students to residents to fellows to attendings. And first, I think that was awesome for patients to get a breakdown of what all of those roles are and what to expect of each provider at each role. But in the education from a medical student to an attending, how can we better incorporate these principles, into like the course of practice of medicine, which Dr. Wayne, you talked about being a part of when you were a medical student, and I'm a part of now, to really shy away from, these are the core objectives to obtain this information from the individual, to approaching the individual as a person and compassionately involving them in their care.
Medical education and medical training is so critical for imparting these lessons. I actually find that, there's an exercise that I do with my students now, and I ask them to take a history. And when they're first-year medical students and have not really learned how to take a history, so to speak, right, ask about where's your pain, where does it radiate, what are the other symptoms. Before you learn all these things, these students actually take a very good history, because what they're doing is they're listening to the human story. They're listening to the context of the illness. They're trying to understand the holistic picture of a person. It takes them a little long because they don't know what to look for, but they're able to get a very good history. When they're third-year medical students, they've learned all these other questions to ask, and they actually don't do nearly as well in getting the history. And I think it's really sad that as interns and residents, a lot of my trainees actually refuse to do this exercise because they almost can't envision not asking questions as a way to get at the diagnosis. And I think that's a failure in the medical training. I actually think that the first and second year training, the preclinical training, and the PLM courses and all those other things, we're doing fairly well there. We're getting the right ideas across. But the problem is what happens in the clinical years. Because we know that in medicine, everything is about modeling and everything is about apprenticeship. And we need to be able to train our senior doctors to do a better job of modeling this behavior for juniors. And similarly, we have to train our residents to better model this behavior for our medical students. Because if we don't do that, then we're not really showing our medical students how this can be done. And so my advice for trainees would be to find attendings and residents and whoever is more senior to you who exemplify the type of doctor that you want to be. And look at their style. See how they do it. See how they handle conflict. See how they tell people bad news. See how they interview patients to really understand their story. And I think in a way, we almost have to get back to the one-on-one apprenticeship model because there aren't always great role models out there for this type of behavior. So it's important to identify the ones that you feel are the ones who are caring and humane and are good at listening and in participatory medicine.
Absolutely. And I thought, getting back to what you're saying about the one-on-one apprenticeship model, when you talk about the different eras of care early on in the book and how we've transitioned from, like tribal healers up until, the last century's medicine where it was this apprenticeship model, it definitely did feel like a lot of that transition of what it meant to be a compassionate physician was sort of lost in that translation to the current era of testing. Whether it be because there just wasn't tools available to provide concrete answers, so people relied more on their interpersonal relationships. It was just something that really struck me from the book that I really appreciated. So I guess continuing kind of in that vein of some challenges for educators and learners and in developing a practice that's based in participatory care, how can we sort of foresee personal challenges in doing this and maybe overcome any? Or are there any personal challenges either of you have experienced in employing a more patient-centered approach to your interview?
Well, I mentioned that sometimes I was answering that question earlier, that language barriers are sometimes, I think, my biggest issue. But I also try to think about those cases. How can I do better? So what can I do to kind of connect more with a patient when I feel that there is that barrier there? And so I think if we approach those patients not as ones where we're not going to be able to connect and understand why they're here, but as just a challenge, like we would an interesting case, and try to learn more from those cases and kind of develop a way of better communicating. I think that it's just a change in mindset. I'm realizing this is probably the most important thing that we do for these patients, or any patient, is how we're communicating with them and making sure that they understand why we're doing, what we're thinking, and that we understand why they're there.
I think that's a really good point, right? That communication ultimately is critical. And I love your point about how you see these patients who otherwise might be perceived as being difficult in some way as a challenge. And I think that's exactly the right mentality. I mean, I totally agree with you. I think, often we in medicine, we have our prejudices regarding patients. And I don't mean we're prejudiced against them and that we think they're less as people. I just mean that we think of certain individuals that we see as difficult cases. We dread going into that room because we're going to be using the translator phone because this patient is deaf and we can't communicate with them. Or even patients in a wheelchair. We're thinking, oh, this will take a lot of time. I don't know what's going on with them. I have to get them undressed to get them out of the wheelchair. I mean, there are all these, whatever these prejudices we have, I think it's actually important for us to, first of all, be aware of them and to not brush them off and say, well, I'm a person who, I never have prejudices against my patients. I mean, I think it's important for us to acknowledge whatever unconscious or subconscious biases we might have and then address them. and say, I'm going to take even more care with this patient because I know that there is this barrier in place. So I think I totally agree with you on that point. The second challenge that people often cite is that of time. And I fully understand this. I also work in a very busy urban ED. It's very challenging when you have 25 people waiting for you to be seen, or 50 people, or 80 people, however many in the waiting room. You feel the urge to see the patient in front of you as quickly as possible. And even if it means ordering chest x-ray and labs, at least it gets them out of your hair for a moment. But that's not really good care at the end of the day. And actually, I would love to do a time motion study to look at this, because I actually think that if you order random tests on people, you're going to get, first of all, random results, right? But then you're also going to spend time looking up these random results and then explaining abnormal ones. So you look at a chest x-ray, or you order a chest x-ray that the patient may not really have needed. Now you're going to be reading the chest x-ray yourself, trying to explain what this lung nodule is that you found, trying to set up outpatient follow-up for this patient for something they never needed in the first place. And so, the time issue is one that I'm very conscious of, but I actually think that we would save more time if we did conscious, active listening, rather than just assume that patients need certain tests that they may not. But I think the biggest challenge for all of us as providers and as patients is overcoming this culture that is so prevalent in the opposite direction, that participatory medicine is something that's not going to be effective, but that's very difficult or whatever. And I would say baby steps, right? I mean, you don't have to start tomorrow and do this for every patient every single time. Try it for one patient. Maybe it's easier for the patients initially who are highly literate, who want to be involved in their care, who are already Googling their symptoms, right? Try it with that patient and try to partner with that person and see what that relationship feels like, to be able to explain the diagnosis, to explain your thought process, to explain testing, etc. See what that feels like. And then move to the more difficult cases. And as you were just saying, embrace the difficult cases too as challenges for you personally and professionally.
That sounds great. Before I guess we come to a close of our discussion, are there any other final thoughts or challenges, concerns that either of you guys would like to talk about?
I think for me, just always be aware of what is that patient feeling at that moment. Think about how scared you would be if you were not in medicine, and or even if you were in medicine, it's still really frightening to just have this total loss of control over your life. And it's understandable why patients are scared. And so it is our duty to reassure our patients and ultimately, at the end of the day, make them feel better after having seen us.
Absolutely, and I think that's a great place to wrap up. So again, you can join us on ALiEM on the book club page for continued discussion of When Doctors Don't Listen. We'll be discussing it on Twitter and on the comment section. Starting on October 10th, we'll have the post ready to go, and it'll be out there. Then you can join in. It's a great read, recommend it for everybody, and go ahead and if there's patients in your life that you think would greatly benefit from it as well, which would be all of them, you should go ahead and give them a copy. Thank you guys for participating. It was a real pleasure.
Thanks, Scott. And thanks, Dr. Wen.